Hello, everybody. Today we will discuss the management of Class 3 malocclusions. Now, at the end of the topic, the student should be able to explain Class 3 malocclusion and its clinical features, the etiology of Class 3 malocclusions, should be able to differentiate between the various types of Class 3 malocclusions and explain the treatment approaches of class 3 malocclusions according to the various stages of development. Now, a class 3 malocclusion is the least common type of malocclusion in many communities. The incidence is less than 5%, and this incidence shows ethnic variation, the highest being among Japanese and Koreans. The Japanese, it's about 5 to 10% incidence, whereas the Caucasians, it's only about 3%. Okay, how do we define a class 3 malocclusion? This is defined as two or more lower incisal edges occlude anterior in front of the cingulum plateau of the upper incisors, and this is in accordance with the British Standards Institute incisor classification. The overjet is reduced, or there may be a reverse overjet. Now, the mixiobuccal cusp of the upper first molar occludes posterior to the buccal groove of the lower first molars, and this is the Engels classification of a class 3 malocclusion. Now, what are the etiological factors involved in a class 3 malocclusion? The main factor, etiological factor, is hereditary. As you can see on the pictures here, this is the so-called the Habsburg family, and which are famous and well known for the class 3 malocclusion. Now, the soft tissue, the next etiological factor is the soft tissue or functional factor. Now, a tongue may be positioned low and in a more anterior position, or it may be enlarged as in macroglossia. Now, the adenoids, enlarged adenoids also is a factor, as well as the habitual protrusion of the mandible. Now, dental or local factors, you can get occlusal prematurities, which cause the jaw to be displaced in a forward direction, as well as due to an abnormal eruption pattern. Now, pathological factors include unilateral or bilateral condylar hyperplasia, cleft lip and palate, whereby the maxillary growth is retarded, craniofacial syndromes, as well as trauma to midface, which again causes a reduction in the growth of the maxilla. Now, we can classify a class 3 malocclusion in two ways. One is whether it is a true class 3 malocclusion or is a pseudo class 3 malocclusion due to a habitual or postural displacement of the mandible in a forward direction. Another way of classifying a class 3 malocclusion is whether it is a skeletal class 3 malocclusion or a dental class 3 malocclusion. Now, what are the clinical features of a skeletal class 3 malocclusion? Let's have a look at the extraoral features. The patient presents with a concave facial profile, and this may be due to a prognathic mandible, or it may be due to a forward positioning of the glenoid fossa, which causes the mandible to be displaced forwards. It may be due to a retrognathic maxilla or a short cranial base. Now, the cranial base angle also has an effect on the position of the mandible. And the class 3 can also result from a combination of any of these factors. Now, students should be able to recognize facial profiles. On your extreme left, what you see is a convex facial profile, and your extreme right is a concave facial profile. And in the middle, you see what is known as a straight class 1 facial profile. So class 3 malocclusions present with a concave facial profile as seen on the extreme right. Okay, now students should also be able to understand what is meant by facial divergence. Now, facial divergence has only got relevance if the profile is straight. And on the extreme left, we see what is known as a posteriorly diverging straight profile, and on the extreme right, you see what is known as a anteriorly diverging straight profile. Now, again, look at the skeletal pattern. In A, we have what is known as a dental class 3 malocclusion, whereby the the dental relationships, incisor relationships are class 3, but as you can see in the diagram, the maxilla and the mandibular skeletal bases are positioned normally. Now in B, we have what is known as a skeletal class 3 due to a retrognatic maxilla, but the mandible is in the normal position. In C, what we is again a skeletal class 3 malocclusion, but it is due to a prognatic mandible, whereas the maxilla is normally placed. In D, it's a skeletal 3 malocclusion, whereby both the jaw bases are at fault, whereby the maxilla is retrognatic while the mandible is prognatic. Now, what are the intraoral features of a skeletal class 3? Intraorally, we will see a class 3 molars which can be unilateral or bilateral, a C class 3 canine relationship, and there may be a class 3 incisors whereby the overjet is reduced, or it may be a age to age relationship, or it may even have a reverse overjet. Now, there may be a posterior crossbite due to a narrow upper arch, and this crossbite can either be unilateral, or in more severe transverse discrepancies, it may be a bilateral crossbite. Now, the dental class 3 extraoral features, the facial profile may be concave or straight. Now, the intraoral features of dental class 3 are we may get class 3 molar relationship. The canines are in uh, class 3 relationship. This is whereby the upper canine does not sit on the embrasure between the lower canine and first premolar, but position more posteriorly, as can be seen in diagram 1 here. Okay, the intraoral features of dental class 3 are class 3 molars, class 3 incisors, and may have a class 3 incisors. And as can be seen here, it can be a reduced overjet, it can be an age to age relationship, or it can be a reverse overjet. Now, the clinical feature, the intraoral features of dental class 3 are the crowding tendency in the upper arch. This is because of uh, retrognathing maxilla, which is smaller in size compared to the mandible. And there also will be seen a dental compensation whereby the upper incisors tend to be proclined, whereas the lower incisors tend to be upright or retroclined. This is a feature of compensation whereby the dental occlusion is compensating for the uh, class 3 incisors. Now, what are the cephalometric features of a class 3 malocclusion? Okay, we would get the cranial base length is short. Okay, now this is the anterior cranial base from nasion to sella, and then the posterior cranial base is from the sella to either articulare or to basion. Okay, so both cranial bases may be shortened. Now the cranial base angle or saddle angle is between the angle formed between the anterior cranial base and the posterior cranial base, and this angle tend to be reduced in a class 3 skeletal pattern. Now the gonial angle, which is formed by the articulare gonian, and from the gonian to nathian, this angle is increased and the mandible is positioned further forward. Okay, now continuing into cephalometric features, now the maxilla to the cranial base, which is given by the SNA angle, may be normal or reduced. It is normal in a normally placed maxilla, reduced in a retrognathing maxilla. Now, the mandible in relation to the cranial base, as reflected by your SNB angle, may be increased or normal. Again, it is increased in when the mandible is prognathic and normal when the mandible is normally placed. Now, the maxilla to mandibular relationship, as reflected by the A and B angle, is reduced, and the width measurement will, gives a reading of more than 0 millimeters, which will be negative measurement. Now, the upper incisors to the maxillary plane, which is this angle, will be increased, and the lower incisors to the mandibular angle tend to be normal or reduced. Now, this is because of the dental compensation whereby the upper incisors are proclined, whereas the lower incisors are upright or retroclined. Now, facial growth in class 3 malocclusions. Facial growth is usually unfavorable. This is because as growth continues, the mandible becomes more prognathic. The age to age relationship tends to become into a reverse overjet, and if it was already a reverse overjet, this reverse overjet will get worse. Now, continuing growth in the vertical direction causes a skeletal open bite. Okay, facial growth. As you can see in this graph, now this is the growth of the maxilla. Now this purple outline is the growth of the mandible in females, and the blue outline is the growth of the mandible in males. As you can see, the maxillary growth is finishes early, and by about 10 years of age, most of the maxillary growth is completed. So, but the mandible will tend to continue growing until at least about 20 years of age in the male. This means the class 3 malocclusion tends to get worse with continuing growth. Okay, management of class 3 malocclusions. There are certain factors that we have to consider in determining the management of class 3 malocclusions. One is patient concerns. Now, uh, the patient, we have to consider what is the patient concerned about, whether it's just the teeth or whether they are concerned about their profile of their face. Now, this will determine how we going to treat the class 3 malocclusion. Now, severity of the skeletal discrepancy. This determines whether treatment can be done by just camouflaging, as in corrective orthodontic treatment, or the patient will need orthodontic surgery. Now, remaining facial growth is also a factor for consideration, because any borderline class 3 that is treated before the pubertal growth spurt will most likely relapse due to growth. And the degree of dentoalveolar compensation that is present also determines how much a treatment can be achieved, correction can be achieved purely with orthodontics, because existing compensation will limit the ability to compensate further. Now, another factor to look at is whether the patient can achieve an age to age incisor relationship. If they can achieve a age to age incisor relationship, that is more likely that corrective orthodontic treatment or camouflage will be successful. Now, the presence of a overbite also is important, because a deep overbite will improve the post-treatment stability. Lack of overbite or a shallow bite will most likely cause relapse. And also, we also need to consider whether, if there is, apart from the AP discrepancy, whether there's any other associated vertical or transverse discrepancies. The presence of vertical or transverse discrepancies will make treatment more difficult, and most likely the patient will need orthodontic surgery. Now, what are the benefits of treating a class 3 malocclusion? Most obviously, it is an improvement of the dentofacial aesthetics. Okay, then with the treatment, we can also eliminate any presence of mandibular displacement, as in a pseudo class 3 malocclusion. Now, this is important because to avoid attrition at the premature contact site, and displacement of the mandibles tend to produce temporomandibular joint dysfunction later in life, and this can be prevented. And also, the premature contact and the displacement of the mandible puts a strain on the lower incisor periodontal tissues due to the presence of an anterior crossbite. Now, treatment may improve the masticatory function. This is so especially in severe class 3s with an anterior open bite. Now, obstructive sleep apnea may also benefit from treatment of malocclusion, because a retrusive maxilla reduces the size of an airway, and correcting this retrusive maxilla by advancing the maxilla increases the size of the airway and may bring about relief in obstructive sleep apnea cases. Now, early treatment of class 3 malocclusions may simplify later definitive treatment. Okay, so this is the treatment plan for class 3 malocclusions. Now, the important considerations here when considering treatment plan for class 3 malocclusion, one is whether it is a growing patient or a non-growing patient, and we also need to see if it was a skeletal class 3 or a dental class 3. And the next consideration, if it's a skeletal class 3, we have to consider which jaw is at fault or both jaws is at fault. Now let's have a very brief look into management of class 3 malocclusions, and we can look at this treatment at various stages in development of a child. Okay, first of all, the pre-adolescent child or the early mixed dentition. Now, in this situations, if there's any retained primary incisors which are causing uh, the permanent incisors, central incisors, to be deflected palatally, then these primary incisors should be extracted early to allow the permanent incisors to align and erupt in a proper position. Now, any anterior crossbite associated with forward mandibular displacement should be corrected early so that to avoid a pseudo class 3 becoming a true class 3 malocclusion. And then this can be easily be undertaken with a URA incorporating a Z spring or double cantilever spring or some form of screw. Okay, or you can use a simple fixed appliances. As we can see here, this is a 2 by 4 appliances. 2 by 4 means, that means the 2 refers to the two molars which are banded and the 4 incisors which are bonded. Okay, now the pre and the late mixed dentition, uh, treatment can be undertaken to correct a skeletal discrepancy. Now, for a retrusive maxilla, we can use a protraction face mask with rapid maxillary expansion. Okay, this can be achieved either with a delay type face mask or a petit type face mask. Other face masks are also available like Grommon's face mask. Okay, we can also use a modified tandem appliance or MTA. This can be seen in the diagram here. We could use a Hickam reverse pull here or even a bone anchored maxillary protraction. The bone anchored maxillary protraction is the elastic forces are not conveyed through the teeth, but it is conveyed through um, anchorage devices which are anchored directly into the skeletal base of the maxilla. Okay, now we are still in the late mixed dentition. If the child has a prognatic mandible, then a chin cup can be used together with an headgear to restrain the mandibular growth. Now, if the patient has both a prognatic mandible and a retrognatic maxilla, a functional appliance can be used. Now, the effect is more dentoalveolar than skeletal effect, and this myofunctional appliance can also be useful as a retainer after the orthopedic treatment. Now, the type of functional appliances that could be used for these purposes are a function regulator 3, a reverse twin block, or a class 3 bionator. Okay, now in the permanent dentition or adolescent child, we can, for mild to moderate class 3 cases, we can undertake camouflage or corrective orthodontics, whereby the aim is to procline the upper incisors and retrocline the lower incisors to achieve a class 1 incisor relationship, and this can be combined either with extractions in both arches as in the top diagram, or the extractions could be done in only a single arch. Now, and this correction of incisor relationship can be easily be done using class 3 elastics. Now, in the class 3 elastics, the lower labial segment is um, retracted, causing them to be upright or retrocline, and the upper buccal segments are brought forward, which will cause the upper labial segment to be proclined. So this will help in achieving a class 1 incisor relationship. Okay. Now, what are the indications for corrective orthodontic treatment or camouflage? Now, one is the patient should be past the peak skeletal growth, meaning the pubertal growth spurt should have been completed. Now, the reason why this is important is because if a camouflage or corrective orthodontic is done when the patient is not still growing, that means not past the pubertal growth spurt, then whatever treatment that is done will be undone by the continuing growth. Okay, and there should be no pre-existing dentoalveolar compensation, because otherwise the corrective orthodontic treatment will not be able to compensate further. Now, the ability to achieve an age to age incisor relationship. Now, there should be an adequate overbite with a normal or slightly reduced lower facial height. So, this is to ensure stability at the end of completion of treatment. Now, it should be a mild to moderate skeletal class 3 relationship with an A and B angle greater than 0 degrees. Okay. Now, once crowding and mandibular displacements are corrected, molars relationship is less than half unit class 3. Now, in adults, if the malocclusion, or discrepancy is mild or moderate, then the treatment is the same as in an adolescent. But if it is severe or if it's associated with asymmetry or vertical discrepancy, then the patient will need orthodontic surgery, and this can be undertaken in either jaw or involving both jaws. Okay, in the lower jaw, the most common procedure done is the bilateral sagittal split osteotomy, whereas in the maxilla, the procedure that is commonly done is the left 4-1 down fracture. Now, another modality that can be utilized to correct a skeletal discrepancy in the adults is to undertake distraction osteogenesis, whereby the whereby the maxilla is distracted to induce the maxilla to grow further. Okay, stability and relapse. Now, a relapse of a class 3 malocclusion is caused usually by two main factors. One is an inadequate overbite, and this means the overbite is insufficient to maintain the corrected incisor position. Now, the second factor is the unfavorable growth. Now, if the growth is unfavorable in the AP direction, the overjet correction or reverse overjet correction will tend to relapse. Now, if the unfavorable growth is occurring in the vertical direction, there is a relapse of the open bite correction. Now, this also means that retention need to be continued until active growth stops. Okay, so these are the references for the this topic, and thank you. Okay, for thank you.